So I'll be talking today about endogenous endophthalmitis, a devastating illness that many of us are obviously very familiar with and strikes all over the world, including India and here in America. And exactly we'll be talking about how it relates to screening in terms of bloodstream infections. So I have no financial relationships. So essentially this devastating illness we try to look out for, and there's a current practice in mind by the Infectious Disease Society of America that advocates for a routine eye exam for every patient that has candidemia growing in the blood, regardless of the clinical status. It's one of the most common consultations, at least here in America, in the hospital setting. And it's puzzling to many ophthalmologists as to why this might be occurring, because it doesn't seem to match up with the guidelines in some way in terms of how frequently we're actually seeing this, because it seems as if it's quite rare. So looking into where this guideline sort of came from, we were digging back into the literature, and in our own American Academy of Ophthalmology journal, 1982, we can see that there is a very high incidence rate reported with patients with Candida bloodstream infections, up to 37%. And you can see here in the photograph, three-dimensional view, you can see that there is a white fluffy lesion coming from the macula into the vitreous cavity, consistent with endophthalmitis. And so clearly this is a very high alarming statistic to have with someone with bloodstream infection. So with this in mind, it makes sense. We would want to find this and treat it appropriately before there was actually vision loss. However, we move forward about 12 years later in a prospective multi-center study looking at 3 different centers here, including Duke actually and University of Pittsburgh. They found, just looking at strict criteria using NIH Newson-Black criteria and using criteria such that vitreous cell had to be involved for endophthalmitis diagnosis, that there were actually no cases of endophthalmitis at 3 different centers over 2.5 years. Now, keep in mind too, this classification also calls for looking specifically at the retina and choroidal lesions as well, and notifying that many of these are non-specific, including different hemorrhages, cotton wool spots that can be hard to distinguish from chorioretinitis. And many of these findings, as we know, can actually be explained by other underlying comorbidities that are present in addition to candidemia during diagnosis, and can actually explain these findings rather than the candidemia. So we move forward about 20 years, and the questions are being raised and the data is being replicated. We're not really seeing this endophthalmitis in this setting, in this routine screening. Do we really even need to be doing this screening? What is actually happening? And so questions are arising. Why is there this decrease in endophthalmitis from the 80s and so on? Are we just finding the candidemia faster in the bloodstream with organisms? Do we just have better systemic antifungal therapy? Do we have better therapy getting into the eye? And most importantly, should we even continue screening? And so what our group did was we had 2 main objectives. One is to determine the actual rate that sight-threatening disease in the setting of candidemia is actually occurring. And then 2 is figure out what are the actual outcomes of this indiscriminate ophthalmologic screening for candidemia. And so to do this, we looked at all possible studies we could throughout the literature, and we were able to find 38 studies of 7,500 patients approximately, looking specifically at fungal organisms in the bloodstream, leading to routine screening. And so we go back to this paper in 1982, and keep in mind, this is not the only one, and looked at their actual definition of what endophthalmitis is. And here you can see in their definition, they include typical white fluffy retinal lesions. No mention about the vitreous. And in one of their example photographs, we can see here, there's a whitish lesion behind a blood vessel. And so at most, this could be chorioretinitis, and maybe even just a retinal cotton wool spot, which again is non-specific and may not even be infectious. There's no evidence here of any vitreous inflammation. As we know here from this slide and others, this is a classic example of endophthalmitis. This comes from the late Dick Green, who's in his eye pathology lab here at Wilmer. And you can see here on this H&E stain, we have clearly budding yeast with polymorphonuclear infiltration extending from the choroid across that purple line showing Brooks membrane into the retina and then vitreous. And this is classic fulminant endophthalmitis. And so this is what we're looking for our definitions. And so when we're looking at these studies, we decided the criteria to require endophthalmitis to have that frank vitreous involvement per Newson-Black criteria. And we classified the studies that adhered to this as concordant, or if they didn't, and lumping other things along with that as endophthalmitis as discordant. And what was pretty striking was using 1994 as a cutoff based on that study by Donahue et al. With a multi-center prospective investigation where they didn't find any endophthalmitis, we used that as a pivotal date, and we actually found that the incidence of endophthalmitis was significantly lower after 1994 than before 1994. And furthermore, if you were to actually do a delineation between a comparison between concordant and discordant definitions of endophthalmitis, it is actually strikingly higher with discordant endophthalmitis. And in reality, it was actually less than 1% with true endophthalmitis rates, whereas it was closer to 15 or 20% in those that were discordant. And interestingly as well, even in the cases with true endophthalmitis that fit the definitions, there were actually no cases of these 7,500 patients that had any intraocular evidence of fungal organisms. And so that just goes to show how much of a diagnostic challenge these cases can actually be, even in the setting of candidemia. So what about chorioretinitis? I mean, we know that can be sight-threatening too, right? And what happens to the cases of true endophthalmitis? I mean, certainly if ophthalmologic intervention can change outcomes there, wouldn't we still want to find those? And so we looked at these as well, and we found that over on the left side of the screen, we have our chorioretinitis, and on the right side of the screen, we have our endophthalmitis. And those that had good systemic management per IDSA, meaning at least 2 weeks of systemic and immediate antifungal treatment with exchange or removal of central venous catheters, actually had success. And if you look in the endophthalmitis group, they had an association of success with medical management only versus that with invasive management. Now, the numbers are small for this comparison because, again, this is a rare disease to have in this setting. And so the limitations, of course, is they weren't randomized, small numbers, but still, at least there's no evidence supporting that there is an improvement in outcomes by doing this screening paradigm. And so, in addition to those findings, there is actually high mortality rates, as we know. Patients with candidemia are very sick. About a quarter to a third end up dying within 6 weeks. And so where are we missing the picture then? So we look at one of the largest studies to date of culture proven endogenous fungal endophthalmitis from the vitreous, comes out of Bascom Palmer. And what's interesting is only 12% of these patients actually had a positive fungal blood culture. It's completely different than the screening paradigm where we're not seeing any in the vitreous. And so these patients come in with symptoms, they come to the emergency room, they come to clinic with symptoms. And this is where we're finding the endophthalmitis. It's not from the screening paradigm. And now the EVS study is a completely different cohort of endophthalmitis. It's exogenous, it's post-surgical, from anterior segment. And so it's hard to make that comparison, but fungal endophthalmitis can be very devastating. It has relatively more than triple retinal detachment rate. And so it's not unexpected that even when we have invasive intervention, we don't have guaranteed outcomes. And something with a screening paradigm, you want to have a good outcome when you are able to screen something anyway. So what about changes in systemic therapy? Well, there's this concern that maybe the screening is still pertinent because echinocandins are a newer systemic therapy, doesn't have that great of vitreous penetration. However, Spain was ahead of us. They actually looked at this. The CandyPop study was a multi-center study throughout Spain, prospective, and they didn't find any differences in the eye findings of those patients who were on echinocandins versus those who are on traditional therapies with azoles and amphotericin that traditionally has better vitreous penetration, supposedly. And this makes sense if we go back to histopathology. So this is out of Fuss's lab in Los Angeles. And you can see here, the typical lesions are in the inner choroid. And so this is part of the systemic vasculature outside the blood retinal barrier. So it makes sense. If we're getting these seeds from the inner choroid, it shouldn't matter what the vitreous penetration is if we're getting, again, the underlying cause, which is Candida bloodstream infection itself. It shouldn't really matter what the vitreous penetration is. And if there is inflammation, the breakdown of the blood retinal barrier should allow that medication to get into the vitreous anyway. And so this is also replicated now with our conventional imaging techniques with OCT. And we can see here where the yellow arrow is that the inner choroid is still where we find it in vivo and not on autopsy. And so this relates even today, as COVID has clearly devastated, and we try to recover this here. And obviously it's hit countries also like India extremely hard. Ophthalmology, we're in a very particular sensitive situation with our patients. We're ophthalmologists, again, are close proximity. We've shown that we're at higher risk of transmitting diseases like COVID. Now, this does not obviate the necessity of an exam ever, but it just goes to show that when we do these exams, something like an eye exam is not necessarily always trivial. There's always risks to everything that we do, and minimizing things that may have potential harm are important to recognize. And so this is what led to 3 of our institutions here in the States to stop this screening practice. And this is part of the paradigm of de-adoption in terms of harmful or less useful practices, so overuse and misuse. And so the British were ahead of us, and they actually implemented this and doing it on an exceptional case-by-case basis. So again, it's exceedingly rare in this setting, and the important thing is treating the underlying cause. Ophthalmologic screening intervention may lead to more harm, and really we should be doing a targeted approach based on looking at the entire clinical picture. Thank you all so much for having me. I really appreciate it.